have reached each governor every time that we have reported to them. Secondly, we have produced 6 policy documents that have been spread around not only Kenya but globally, showing exactly where we are. Thirdly, we are the only part of the world, not just Kenya, that invented its own predictive model for COVID. Governors, the only working predictive model for COVID in the world is here. And this is now being hailed as one of the best innovations that can ever happen, done by our own scientist here. Professor Shem Otoy is here. We have published it internationally in international recognized journal, and it is now recognized. Last week, in a meeting by the Gates Foundation and KEMRI that brought in scientists from South America, from Asia and everywhere, it was agreed that it is the only model that can give the prediction 3 months before COVID hits you. This predictive model then is the one that we use to help us fight some of the earlier scourges that caught us here, and we did so successfully. So apart from this innovation, we have also established the only workable dashboard that shows every governor and every person on a minute-by-minute live basis the cases that have been diagnosed that day, that hour in a county, the vaccination that have been done in that county, the staff that are available or are not available that can take care of COVID, the availability of oxygen in each one of our counties and treatment centers, the specialists that are free to take care of your chest problem, the level of medication that is available in every county, the number of ICU beds that are open and free in every county. We did this for 2 reasons. Patients were having problems identifying where they could go when they were seriously sick. You could come to Jaramogi and you're told that the beds are full, but the beds in Kisii are still empty, or the beds in Bosu are still empty. So we decided that we bring in a coordinating virtual system that would allow our staff and our people to know exactly where they could get help. By the end of that, we ended up being the best coordinated region in terms of IU beds and intensive care, and also the best supplied region with oxygen. Oxygen could be available in one place but not in another, but in this region you could tell exactly where it is and you could call that place and get that moving. With those things happening, we have been able then to put not only our region in the map, but to show that it is possible for us to achieve the impossible. What lessons are we learning from this? Ladies and gentlemen, there are things here. First, most of you don't know that in terms of schools of health sciences, the LREB region has the highest concentration of schools of health sciences in Africa. You just saw the VCs here. Virtually each one of them has a school of health sciences. Unfortunately, that concentration does not reflect in our health outcomes. In most parts of the world, when you have very many schools of health sciences, it reflects on the good health of the people. The best is the area of Boston in the US. We are the Boston of Africa. If we had the confidence and the engagement of all these schools of health sciences, there's absolutely no reason why we shouldn't be competing with Boston and other parts of the world. They are here already, the expertise is here, it is up to us to use that. Secondly, it is important that we use data. And the data that we have used in COVID has made this difference. Unfortunately, so far, health data is not being used well, and we are not digitalizing. We've got to digitalize, we've got to use everyday data to show which woman is dying there, where, why that woman dies, and why the next death must not take place. It is possible. We have schools, we have the expertise, and we can do it. Thirdly, it is oversight. Our committee were able to provide, with the permission of the governors, extreme and intensive oversight. Ladies and gentlemen, we are not providing enough oversight on our health services. And that oversight, or lack of it, is reflecting in two areas. One, wastage. There is far too much wastage in this area. Two is dishonesty. This sector is dishonest, and you allow it to happen. Two areas of dishonesty that I want to emphasize on. One is fiduciary dishonesty in terms of procurement and the use of resources. If you don't stop it, you will not be healthy. Two is professional dishonesty. A lot of the people that you employ are not at work. Absenteeism is extremely high. And part of the absenteeism is not because people are sick or unwell, but it is because people are attending seminars and conferences supported by the donors and opened by the governors. It is important that we are employed to work, and we work diligently. We do not have an absolute shortage of manpower, but we have major problem in the management of human resources. This has to change if we are going to move forward. And finally, governors and ladies and gentlemen, if there is one part of Kenya that should not complain of shortage of brains in health, it is the Lake region. Yesterday, I did tell you that in the time that I was in the medical school, all my teachers came from Busia, Siaya, Kisumu, and Kisii. But the worst health outcomes are where my teachers came from.
So there is a question here of how we attract our people, wherever they are, to come and work at home and make a difference at home. COVID has shown us that this thing is possible and we can be able to move forward. So my appeal is this. You gave us a task as a committee, we delivered. You can decide on what to do with our committee. It has been voluntary, all of us were giving voluntary time, and we do not want to be paid a penny. But the lessons that we've given you are very, very clear. So the people of these counties are willing to pay back to the counties. My final point, the app that we've used for monitoring COVID can also be extended for monitoring all communicable diseases and non-communicable diseases. That app, we are giving it to LREB, to the counties. You can, free of charge, you can extend it if you want to cover all those on a minute and day-by-day basis. That is going to be important because COVID is just the first of the many pandemics that we are going to be facing in the future. The future of health in our region is safe, but it will depend on how you use our resources. Thank you.
Thank you so much, Prof. Let's appreciate the Prof again, please. And Prof is one of the best brains we have here in health. One thing he has talked about, why the next death should not occur. And on that note, Your Excellencies, allow me to invite Zipline to make the presentation. We have Njeri here, Winfred Njeri, Director, Zipline Kenya. She will make a presentation equally on health matters. Thank you so much, Zipline.
The Chair, LREB, all the governors represented here of LREB, the CEO LREB, dignitaries, ladies and gentlemen, good morning. My name is Winfred Njeri, and I'm the country manager for Zipline Kenya. I don't know how many of you have interacted with Zipline before in Africa. Zipline, we're an instant logistics company. Mostly our main mission on earth is actually to ensure that every human on earth is able to receive medical products or essential commodities, for example, blood, at the time they need it, with the least effort that the patient should make. Zipline started in 2016 in Kigali, Rwanda. Most of you refer us from Kigali, Rwanda, where we established the first Zipline hub in Africa. We are an American company, but our first operations were actually launched in Africa. Together with our great ambassador in Africa, President Kagame, and we launched Zipline operations in Rwanda, and we've been there for 7 years now. We've expanded to other African countries, which include Ghana, Nigeria, Cote d'Ivoire, and now hoping to launch Kenya in Kisumu in the next few weeks. I know we're a bit late, but we're hoping to launch in the next 3 weeks. We're just waiting for the right to fly, and that is our final stage of us starting operations. Zipline in Rwanda, as some of the governors have visited before, you can see the impact that we have on society, and especially in accelerating universal health coverage. Our target is actually the primary healthcare facilities, which do not get medicines, especially medicines, blood, whenever they need it. You can imagine how much the primary healthcare facilities need for a day-to-day basis. Just like 10 bottles, maybe, of even paracetamol or anti-malarials. But we wait for this big, huge truck every 1 month flagged to get to these facilities, but they actually don't get to these facilities. And you find mothers are losing lives every day when they're giving birth because they cannot access blood at the time they need that blood. Most of the deliveries, they can be emergency, and you find that postpartum hemorrhage is actually high, and that's one of the reasons that our mothers are dying. And one of the impact that we've had in health sector, like for example in Rwanda, is to reduce postpartum hemorrhage by 88%. This is evidence-based.